Perfect.
Okay. We're going to talk about compression neuropathy, and we'll cover these conditions. So first, we'll start with carpal tunnel syndrome, and we'll spend most of the time on this, and we'll cover some of the general principles on nerve conditions. So obviously, it's important if you're treating carpal tunnel syndrome to know the anatomy. The median nerve is contained within the carpal tunnel, as well as all the flexor tendons to the digits, including the FPL. The FCR of the wrist is not contained within the carpal tunnel. That's sometimes a question. The median nerve anatomy should be known when you're treating these. The palmar cutaneous branch of the median nerve in general is not within the carpal tunnel. It branches off approximately 5 centimeters proximal to the wrist flexion crease. There is some anatomic variations where it can actually go within the carpal tunnel, but that's not common. Much more common is anatomic variations within the recurrent motor branch of the median nerve. This was described by Lance in '77. The majority of recurrent motor branches come off along the radial distal border of the transverse carpal ligament, but these variations should be kept in mind when you're releasing the carpal tunnel. So what causes carpal tunnel syndrome? Well, there are many things that can cause it. In general, we say it's idiopathic. It's more common as you get older, more common in women, but certain underlying conditions do predispose you towards developing carpal tunnel syndrome. Most commonly in patients that we see, this includes diabetes and hypothyroidism and increased body mass. Carpal tunnel syndrome can also occur in the setting of an injury, and classically it's a distal radius fracture. It can also occur from tight dressings. In a patient who has a distal radius fracture, either that's treated non-operatively or operatively, you can develop an acute carpal tunnel syndrome, and this is equivalent to a compartment syndrome and is a relative surgical emergency. Diagnosing carpal tunnel syndrome, there are many things that we do and examination, but I would say the majority of the patients, we can get the diagnosis from the history alone. Patients have complaints of numbness and tingling within the hand, aggravated during any activities where they're flexing the wrist. So sleeping at night, reading a book, driving. Sometimes patients can have radiation of their symptoms proximally up to the shoulder. And in latter stages, they'll have weakness in thumb opposition. Sometimes men will describe difficulty buttoning their shirts, putting on a tie. So on to examination, patients will have alterations in sensation, numbness and tingling along the median nerve distribution. And we want to examine this. Now, oftentimes we'll just touch the finger, but this is really not accurate. And as you can see, even 2-point discrimination, which many of us as hand surgeons use, is only 22% sensitive. Really, SEMS threshold tests such as SEMS-Weinstein monofilament or vibrometry are much more sensitive tests. In general, we don't do these. These are more commonly done by our therapy colleagues, but keep in mind, innervation density tests are really only diagnostic in late stages of disease. You want to go on to motor examination, look for weakness or atrophy of the thenar muscles. And then you go on to your provocative tests. We're all familiar with Canal sign, where you're tapping on the nerve at the carpal tunnel. This is a relatively insensitive and non-specific test, as well as the Phelan's exam, where you have the patient flex their wrist down. I'll do it like this, have them hold it for anywhere from 30 to 60 seconds and see if this recreates their symptoms. The Durkin's compression test, where you're putting direct pressure on the median nerve at the carpal tunnel or just proximal to the carpal tunnel, is a much more specific and sensitive test. And in fact, a combination of the Phelan's test and the Durkin's compression test is a much more specific, and one study showed 99% specificity. EMGs, I would say that there's a lot of controversy with regard to EMGs. Oftentimes patients come to my office with EMGs already ordered. Not every patient needs an EMG. You got to compare apples to apples. It's operator dependent. And negative tests do not necessarily mean that disease is absent. In one study, it showed that 8 to 20% of patients with clinically or surgically proven carpal tunnel syndrome actually had negative EMGs or EMGs that showed mild compression. And the other thing is EMGs are not helpful in terms of correlating with outcome to treatment, and EMGs do not necessarily normalize even if symptoms do. So how do we treat this condition? Well, if a patient has an untreated medical condition, you want that first to be treated. Splinting is classically one of the first things that we do, but most studies show that it's only effective for patients with short-term symptoms. I think if you have a patient who has mild symptoms primarily at night, give them a splint, have them wear at night, and see how they do. Steroid injections are helpful. However, most studies show that at 1 year, only 1 in 5 patients have long-term relief. In my hands, I like it to use it in 2 scenarios. One, a pregnant woman who has carpal tunnel syndrome during latter stages of pregnancy. Obviously, a patient has mild symptoms that doesn't respond to splinting. I think it's also helpful in terms of diagnostically predicting response to surgery. So a classic patient has carpal tunnel syndrome as well as a concomitant cervical radiculopathy. They have EMGs, you're not really certain where the majority of their symptoms are coming from. Well, if you give them an injection and they get better, then you can tell them that there's a pretty good chance that they're going to get better with the carpal tunnel release. And medications, particularly vitamin B6, there were a lot of enthusiasm for this, and I still see a lot of patients that are put on this by their neurologists or other physicians. There have been some good longitudinal studies showing no effectiveness on vitamin B6. Gabapentin, it can treat the symptoms short term, but it's not going to treat the actual condition. So how do we treat this? If patients do not respond to non-operative management, we go to surgical release, and you can do the classic open release or the endoscopic release. Difference between the two take-home messages: at 3 months, the results are the same. Endoscopic has been shown to have an earlier return to work. Early on, I would say in the late 80s, there was a higher complication rate shown with endoscopic release, but this really has not been borne out. Endoscopic release has been around for over 30 years, and it's a safe and effective treatment, but really dealer's choice. Antibiotics not indicated for carpal tunnel. This is from the AOS. In fact, antibiotics in general are not indicated for most soft tissue procedures of the hand and upper extremity. Can consider in diabetics and immunocompromised patients or revisions. Post-op has been looked at, splint and casting not necessary, OT except in certain cases where patients develop stiffness or scar tissue, not necessary. And complications, well, failure to relieve symptoms, I guess we can call a complication. Obviously, you want to make certain that you have the correct diagnosis. This can also be secondary to a technical problem, incomplete release. Classically, incomplete release is distally. You want to make sure that you release it completely until you see the fat overlying superficial palmar arch. The median nerve can be injured during surgery. It should not be. Keep in mind that the recurrent motor branch does have the variability in terms of anatomically. In general, it comes out distally and radially. So that's why when we release the carpal tunnel, we try to stay along the ulnar margin. In my experience, a hypertrophic painful scar is probably the most quote unquote complication. These patients generally do get better. I'll treat them with massage, sometimes silicone, and if they don't get better, cortisone injection along the scar. RSD is uncommon, but can happen, and these patients are very unhappy. If you think that a patient is tending towards developing RSD, you want to treat these patients early and aggressively with steroids or medications. Revision carpal tunnel release, general number, 50% of these patients will improve. Obviously, you want to make certain that the carpal tunnel is a correct diagnosis. If there's scar tissue of the nerve, then you want to consider concomitant procedures such as a fat pad or a nerve wrap to prevent rescarring. Go through a couple questions that we covered from the previous from the lecturing. Which physical examination finding among patients with carpal tunnel syndrome has the highest specificity? Well, we discussed wrist flexion carpal compression test, 99% specificity in one study. What is the most common pattern of branching of the thenar motor branch of the median nerve at the level of transverse carpal ligament? Extraligamentous distal transverse carpal ligament, as described by the Lancet study. An otherwise healthy 42-year-old woman is scheduled for carpal tunnel release. The physician should adhere to routine steroidal protocols and nothing. No antibiotics, no antibiotics and irrigation, nothing. Okay. Next, most common compression neuropathy is cubital tunnel syndrome. Patients present with numbness and tingling along the ulnar nerve distribution as depicted below. In latter stages, they will have intrinsic weakness and atrophy. But again, you want to get to these patients before they develop these late stages symptoms. And very late stage, they'll develop an ulnar claw hand, which we'll go into. On examination, you'll perform the Canal sign where you'll tap on the nerve, a compression test where you press on the nerve and it recreates the symptoms, as well as an elbow flexion test. I think the elbow flexion test is probably the most effective in my hands. You want to feel for the ulnar nerve. So you want to flex and extend the elbow and make sure that the ulnar nerve does not sublux. Particularly if you're going to be retreating these patients, this will change what you're going to actually do, and we'll get into that. You want to do sensibility testing, test their motor strength for intrinsic weakness, and look for atrophy. A couple signs, simple, ask the patient to cross their fingers. With intrinsic weakness, they'll have difficulty. Classically, we talk about the Frohman sign, and basically you're asking the patient, if you can see, to hold a piece of paper between their thumb and index in the web space, and because of weakness of the adductor, they're going to flex down that thumb to hold on to that piece of paper. And that's a classic sign for an ulnar neuropathy. Wartenberg sign, you'll have abducted small finger, secondary to an unopposed EDM, weakness of the interossea. I just recently had a patient that was sent to me, a rheumatoid who had a classic Wartenberg sign. Actually, her rheumatologist thought that she had a ruptured extensor tendon, got an MRI, and actually she had a chronic ulnar neuropathy. Not to be confused, there's a Wartenberg syndrome, which is a dorsal radial sensory nerve branch neuropathy. Same person who described them, but different conditions. And the papal sign, where you have clawing. And the latter stages, this can be a fixed deformity. Again, all these signs are late stages, and you want to obviously try to get to the patients before they develop these. So differential diagnosis, I think in cubital tunnel syndrome, it's important to keep this in mind because cervical radiculopathy and thoracic outlet syndrome in particular can mimic cubital tunnel syndrome. They affect the lower trunk. And you want to make certain that these conditions do not coexist, or if these are the conditions that exist. And obviously, important to do a good good physical examination, and if necessary, EMGs. EMGs, most of these patients, again, get EMGs, whether they come with them or we order them. They're not always positive, and much more so than in carpal tunnel syndrome. These patients can have normal EMGs with symptoms that are quite problematic to the patient. I think the classic patient is a young woman with thin arm and cubital tunnel syndrome who may have a negative EMG, but may have symptoms where eventually they may need surgery. X-rays, MRI, not routinely indicated unless the patient has a history of trauma or arthritis or other conditions. Sites of compression. There are classic sites of compression from proximal to distal. There's the arcade of Struthers, which generally is 8 centimeters proximal to the medial epicondyle. This is essentially a fascial structure between the triceps and the brachialis, and is uncommon, but you need to fully release at least 8 centimeters proximal to the medial epicondyle to make certain that you release this. The medial intermuscular septum in and of itself may not be a site of compression, but if you're transposing the nerve, it can kink the nerve, and this needs to be resected. Osborne's ligament is the roof of the cubital tunnel. This obviously needs to be released. Overlying Osborne's ligament, you can sometimes find an anconeus epitrochlearis, which is an aberrant muscle. That's relatively uncommon, depending upon the report. It's present in anywhere from 8 to 30% of specimens. But if you see a muscle when you're opening this up, that's an anconeus epitrochlearis, and you need to release that. The medial epicondyle can be involved more commonly if you're transposing, and you need to release distally, approximately 8 centimeters distal to the medial epicondyle. You need to release the fascia and the two heads of the FCU muscle. So how do you treat these patients? If patients have mild symptoms, particularly at night, you can try an elbow splint, such as this, relatively poorly tolerated. It's uncomfortable. Sometimes I'll tell a patient to wrap a towel around their elbow or take an elbow pad and reverse it. Much more comfortable. Activity modification. Steroid injections have been described. I have not used them personally. So on to surgical release. Your options are in situ release, and medial epicondylectomy and anterior transposition. I would say when I was a resident, if you told a hand surgeon that you were doing an in situ release, they would look at you and say, you don't know what you're doing. But there's been a trend over the past at least 10 years to do less than more, and pretty much most studies have shown that whatever you do, results are about the same. I think there's a trend, at least in primary cases, to do an in situ release, except if there's contraindications. It's a much simpler operation, fewer complications, and certainly an easier recovery for the patient. So what are the contraindications to in situ release? Well, on examination, you have to make certain that the ulnar nerve does not sublux. And after you release it, you need to make sure that the ulnar nerve does not sublux. And when you're releasing it, you don't want to completely circumferentially release the ulnar nerve, because if you do, one, you will devascularize it, but two, it will certainly sublux. Patients with severe RA or OA, where it may impinge upon the nerve, you probably should transpose it. A valgus deformity, if you do not transpose it, they will still have pressure on the nerve from the valgus deformity of the elbow. So you need to transpose that. Prior surgery and revision, you need to transpose it. I would say there's not a complete consensus, but most people will perform a submuscular transposition to prevent scarring. And certain throwing overhead athletes, you want to consider doing an anterior transposition. When you're performing this procedure, you want to protect the medial antebrachiocutaneous nerve branches. If you get a neuroma, these patients will be very unhappy. And here's just a depiction of a submuscular transposition. This is a relatively large operation. You're releasing the flexor pronator mass, completely release the ulnar nerve, and then you want to place it beneath the muscle. Don't kink it. This is actually the median nerve. You want to place it right next to the median nerve. Complications, medial antebrachiocutaneous branch neuroma. Need to avoid this. Patients will be very unhappy. Persistent symptoms obviously can be caused from an incomplete decompression. If you're transposing it, you need to make certain that you do not kink the nerve and that you resect the medial intermuscular septum, and obviously a correct diagnosis. Elbow instability, relatively uncommon unless you're releasing either a medial epicondylectomy or submuscular transposition. You need to be certain that you're not as well injuring the medial ulnar collateral ligament. Couple questions. Was the reason for thumb IP joint flexion with lateral pinch and ulnar nerve palsy? Again, that's the Frohman sign, unbalanced flexion torque of the FPL at the IP joint. The presence of an anconeus epitrochlearis muscle is associated with the slowing of the conduction velocity of which nerve? Well, not necessarily always slowing, but obviously it's related to cubital tunnel syndrome, and it's the ulnar nerve. You can see right here, this is an anconeus epitrochlearis. This is posterior. This is a medial epicondyle. This is a medial intermuscular, medial antebrachiocutaneous nerve branch, and you want to release that. It's actually a good prognostic sign. These patients usually get better fairly quickly. And when comparing in situ ulnar nerve decompression versus anterior transposition in the surgical treatment of cubital tunnel syndrome, anterior transposition affords, they're all the same, no difference in motor sensory recovery. Probably does not matter what you do. Okay, on to Guyon's canal compression, also called ulnar tunnel syndrome. Patients have ulnar numbness and tingling along the ulnar nerve distribution. The dorsal ulnar sensory nerve branch comes out approximately 5 centimeters proximal to the wrist flexion crease. There's some variability, but it does not go through Guyon's canal. So in general, they'll have normal sensation dorsally. Patient can get weakness and atrophy much more commonly than you see in cubital tunnel syndrome. In late stages, you'll see clawing. And clawing in these patients is actually worse than cubital tunnel syndrome, as Dr. Posner had discussed. The FDP of the ring and little fingers remain intact because they're innervated proximal to the cubital tunnel. So with the intact flexion of the FDP of these fingers, your clawing will actually be worse. Etiology, Guyon's canal compression is often secondary to a space-occupying lesion. So I will oftentimes get a diagnostic imaging study such as an MRI. It can also be secondary to an ulnar artery aneurysm. Patients can develop Guyon's canal compression or irritation of the ulnar nerve from a fracture of the hook of the hamate, lipoma, and classically repetitive trauma. We hear about bicyclists. Guyon's canal has been broken up into 3 zones from proximal to distal. Zone 1 includes both the motor and sensory branch, and the majority of compressions in zone 1 are from ganglia. Zone 2 is a motor disturbance just involving the motor branch and again, most commonly ganglia. And zone 3 is most commonly secondary to an ulnar artery thrombosis, which lies right next to the sensory branch and purely sensory symptoms. Again, as I said, in these patients, I will more often than not get diagnostic imaging. As you see here, this space occupying lesion on EMGs usually should be gotten for these patients as well, because you want to make certain that there's no other site of compression. Conservative treatment, you can try activity modification and splinting. If you're going to release this in a patient who has Guyon's canal compression in and of itself, you want to completely release Guyon's canal, and you want to excise any space occupying lesion. If a patient has concomitant carpal tunnel syndrome and Guyon's canal compression, by releasing the carpal tunnel alone, you will indirectly decompress Guyon's canal because the transverse carpal ligament forms the floor of Guyon's canal. Here's one picture. It's not mine, but this is a ulnar artery thrombosis that is compressing the ulnar nerve at Guyon's canal in zone 3. Not only do you need to decompress Guyon's canal in this region, but you need to excise and reconstruct this thrombosis. And this patient probably should get a vascular study as well preoperatively. So one quick question: which of the following is an anatomical component of the floor of the distal ulnar tunnel, which is Guyon's canal? Well, as we said, transverse carpal ligament. It forms the floor, and by releasing transverse carpal ligament, you're indirectly releasing Guyon's canal. And we'll quickly finish up with radial tunnel syndrome. Radial tunnel syndrome is a pain syndrome. Patients feel pain in this area. They describe it as a deep gnawing pain, almost like a toothache. Although this is from irritation of the nerve, it's not from compression of the nerve where you developed a motor or sensory symptoms. So EMGs are not helpful. You want to rule out lateral epicondylitis, can coexist as well. What is the etiology? It can be secondary to repetitive tasks, such as rowers and other type of tasks such as that, trauma, swelling, inflammatory conditions. Most often, I think these patients just develop this similar to other conditions. Tumors can cause not radial tunnel syndrome, but actually PIN syndrome, which should be differentiated because this is actually a motor condition where you will get weakness of the wrist and fingers with extension. And these patients should have EMGs, and lipomas have predilection towards this area. This is a diagnosis that is based upon examination. You have tenderness right in this region. Obviously, when you rule out lateral epicondylitis, pain is increased with resisted forearm supination. I find the diagnostic lidocaine injection can be helpful into that area. You just have to be careful that you're not going to injure the PIN. EMGs and NCVs are not helpful. Do not get them for these patients. From proximal to distal, the radial tunnel, the PIN can be compressed from fibrous bands of the radiocapitellar joint, the leash of Henry, which is a small vascular leash from the radial recurrent artery, the proximal edge of the ECRB, the arcata froche, which is the leading proximal edge of the supinator. The superficial head of the supinator needs to be released, as well as the distal edge of the supinator. So if you're operating on them, you need to release all of these sites. Here's a picture. This is proximal, this is distal, this is a posterior interosseous nerve, and this is actually that leading edge of the supinator, the arcata froche. And as you can see in this picture, it's a real compressive structure that needs to be released. Treatment, majority of these patients do not require surgery. You can treat them with splinting, activity modification. I've had some relief with cortisone injections. If you're operating on these patients, you need to release all potential sites of compression. You can consider releasing the lateral epicondyle, although when you're releasing the fascial edge of the ECRB, you're indirectly releasing the lateral epicondyle as well. And be aware not to injure the posterior interbrachiocutaneous nerve branch. One last question: proximal dorsal forearm pain with supination against resistance is a finding used to support the diagnosis of radial tunnel syndrome. Thanks, guys. I will stop sharing.